Professor Ghulam Siddiq. Today I'm going to share with you a case of a 58 years old gentleman who had history of epigastric pain and jaundice going on for more than 6 weeks. He presented to a hospital in the same city where initial workup including an ultrasound and a CT scan was done. These investigations revealed multiple stones in the gallbladder, and there were obviously three large stones in the CBD. They performed an ERCP where stent was placed, but no attempts were made to retrieve the stones. When the patient presented to us, we gave him the option of laparoscopic cholecystectomy and exploration of common bile duct. The patient agreed with this plan and didn't want to have a repeat attempt at ERCP. We used the standard approach for laparoscopic cholecystectomy and for CBD exploration and subsequent suturing. We placed another 5 millimeter port in the epigastric region. As expected, there were a lot of adhesions in the area of the callous triangle. These adhesions were taken down using blunt and sharp dissection. The Hartmann's pouch was dissected free. The callous triangle was then dissected. The important thing here is that if there are large stones in the common bile duct, the cystic duct is going to be significantly dilated as well. With careful dissection in the region, the cystic duct and cystic artery are both displayed quite clearly. As a basic principle, to minimize thermal injury to the bile duct, the hook cautery should be placed as close to the gallbladder as possible. The cystic duct, as seen here, is quite significantly dilated. The cystic artery is clipped here and then divided. For grossly dilated cystic duct, I found Hemolog quite useful, or alternatively, you can divide and transfix the cystic duct stump. Once the cystic duct and cystic artery are divided, then the fundus area of the gallbladder can be left intact to act as a retractor. But in case where the liver is already fixed to the anterior chest wall, the gallbladder can be completely removed, like in this particular case. Next, two stay sutures are inserted just above the first part of the duodenum in the common bile duct, and the common bile duct is then incised in between these stay sutures. The choledochoscopy is extended further, and a gallstone is retrieved. Another stone is there. Care is taken not to crush the stones at this stage. The stent is visible there, and the third stone probably is lying higher up there. The confluence of the duct can clearly be demonstrated here. Both the right and left duct are seen. Next step is choledochoscopy to make sure there are no residual stones in the bile duct. The choledochoscope passed very easily into the duodenum. The sphincter as well as the distal CBD was thus examined, and no residual calculi were found. As the patient has had a very good sphincterotomy, we did not put a T-tube, rather closed the choledochoscopy primarily. I use 30 Maxon for closure of the choledochoscopy. It's single layer and in continuous fashion. Once the choledochoscopy is closed, the retrieved stones and gallbladder are retrieved in an endobag. The stent is removed separately. The right subhepatic place is thoroughly irrigated with normal saline, and a suction drain is placed in the right subhepatic region. This patient made an uneventful post-op recovery and was discharged home within 48 hours. Thanks for watching.